Most people over 60 who are losing their vision gradually do not connect what is happening in their eyes to what is happening in the rest of their body. They accept it as aging. They get a stronger prescription. They add more lighting to their home. They stop driving at night and tell themselves that is just what getting older looks like. But there is a specific nutrient deficiency, one that is extraordinarily common in adults over 60, one that almost never appears on a standard annual blood panel, and one that has a direct and well-documented biological relationship with three of the most serious age-related vision conditions affecting older adults right now that may be silently accelerating vision loss in a way that is both measurable and, when caught early enough, meaningfully addressable. I have been in medicine for over 20 years with a focused practice in senior health, and what I want to talk to you about today is not a supplement trend, not a wellness industry claim, not something I read on a health blog. It is peer-reviewed science sitting in ophthalmology and nutritional medicine literature that the majority of adults over 60 have never been told about in a standard eye exam or a routine medical appointment. My name is Dr. Michael Kent, and if you are over 60 and you have noticed that your vision is changing, that colors seem less vivid than they used to, that you struggle more in low light, that you need more time to adjust when moving from bright spaces to dim ones, or that your eye doctor has mentioned early signs of macular changes, cataracts, or diabetic eye disease, I want you to stay with me through this entire video because what I am about to share may fill in a piece of your picture that has never been addressed. Before we go any further, please drop your age and your city in the comments right now. I read every single comment, and this information is made specifically for you. Comment your age and city below and subscribe to this channel so you do not miss what I publish every week because this conversation matters and I intend to keep having it. Let me start with the eye itself because without understanding the specific biological environment of the aging eye, the nutrient connection will not land with the weight it deserves. The human eye is one of the most metabolically active organs in the body. The retina, the thin layer of tissue at the back of the eye that converts light into the electrical signals your brain interprets as vision, has one of the highest concentrations of metabolic activity per unit of tissue of any structure in the human body. It demands enormous amounts of oxygen. It produces significant amounts of oxidative byproducts. And it is directly exposed through the lens and the vitreous to light energy, including ultraviolet and high-energy visible blue light, for every waking hour of every day of your life. This combination of high metabolic demand and constant light exposure means the retina is under relentless oxidative stress. The body manages this through a sophisticated antioxidant defense system built into the eye itself, a system that relies on specific dietary compounds that the body cannot manufacture on its own and must obtain from food. When those compounds are present in sufficient amounts, the system functions. Oxidative damage is neutralized. The delicate cells of the macula, the central region of the retina responsible for sharp, detailed color vision, are protected. The lens remains clearer for longer. The vascular structures that supply the retina with blood and oxygen stay healthier. When those compounds are deficient, the protection degrades. Oxidative damage accumulates. The cells of the macula begin to deteriorate. The lens proteins begin to aggregate and cloud. The fine blood vessels of the retina become more vulnerable to inflammation and structural damage. And this process is gradual, cumulative, and largely silent, meaning that by the time most people notice meaningful changes in their vision, the underlying cellular damage has already been progressing for years. The nutrient I'm talking about is lutein, specifically lutein, and its closely related companion compound zeaxanthin. These two carotenoids, plant-derived pigments from the same family as beta-carotene, are the only dietary nutrients that the body selectively concentrates inside the eye. They accumulate specifically in the macula, where they form what researchers call the macular pigment. This pigment does two things simultaneously that are critical for protecting the aging eye. First, it functions as a biological filter, absorbing high-energy blue light before it reaches the photoreceptor cells beneath it, reducing the light-induced oxidative stress at the most vulnerable point of the retina. Second, it functions as a direct antioxidant within the retinal tissue itself, neutralizing the free radicals generated by the eye's extraordinary metabolic activity before they can damage the photoreceptor cells and the retinal pigment epithelium that supports them. The research connecting lutein and zeaxanthin levels to age-related macular degeneration, The leading cause of irreversible vision loss in adults over 60 in the developed world is substantial and spans decades. The Age-Related Eye Disease Study, a major landmark clinical trial, demonstrated that specific nutritional combinations including lutein and zeaxanthin were associated with meaningful reductions in the risk of progression to advanced AMD in people with intermediate disease. Multiple epidemiological studies have found that adults with higher dietary intake of lutein and zeaxanthin consistently show lower rates of both early and late-stage macular degeneration than those with lower intake. The relationship is not casual and not peripheral. It is one of the most consistently replicated findings in nutritional ophthalmology. The connection to cataracts is also well established. Cataracts, the clouding of the eye's lens that affects the majority of adults over 70 to some degree, develop through a process of oxidative damage to the lens proteins that causes them to unfold, aggregate, and lose their transparency. Lutein is present in the human lens as well as the retina. Studies have found associations between higher lutein intake and lower rates of nuclear cataracts, the most common form of age-related cataract. The mechanism is consistent with what we see in the retina. Lutein's antioxidant activity reduces the oxidative stress that drives lens protein damage. For adults with diabetes, and the number of people over 60 managing type 2 diabetes is extraordinarily high, there's a third dimension to this story. Diabetic retinopathy, the damage to the retinal blood vessels caused by chronically elevated blood sugar, is the leading cause of new blindness in working-age adults and a major cause of vision loss in older adults with diabetes. Oxidative stress and inflammation in the retinal vasculature are central drivers of diabetic retinopathy progression. Research has examined whether lutein's antioxidant and anti-inflammatory properties may offer some protective benefit at the retinal vascular level, with findings suggesting that higher lutein status may be associated with reduced severity of diabetic retinal changes. This is an area of active research, and it is something every adult over 60 with diabetes should be discussing with both their physician and their eye care provider. Now, here is the critical problem. Lutein is not made by the human body. It must come entirely from diet, and the primary dietary sources of lutein, dark leafy green vegetables, specifically cooked kale, cooked spinach, and cooked collard greens, are not foods that feature prominently in the daily diet of most adults over 60 in most Western countries. Eggs are also a meaningful source of lutein in a highly bioavailable form, as the fat-soluble nature of lutein means it is absorbed far more efficiently when consumed alongside dietary fat. Corn and orange bell peppers contribute smaller amounts, but the quantities needed to maintain the macular pigment optical density associated with reduced AMD risk are not easily achieved through casual dietary exposure to these foods. And here is something that makes this worse for adults specifically over 60. Lutein absorption from food decreases with age. The digestive changes that accompany aging, reduced stomach acid, changes in bile production, shifts in gut microbiome composition, all reduce the efficiency with which fat-soluble compounds like lutein are extracted from food and transported into the bloodstream. This means that an adult over 60 needs to consume more dietary lutein to achieve the same serum levels that a younger adult would achieve from an equivalent intake. And simultaneously, the oxidative burden on their retinal tissue has been accumulating for longer, meaning the demand on the macular pigment is higher at the exact moment that the supply is becoming harder to maintain. This is the silent deficiency picture. Not dramatic, not sudden. A gradual, decades-long erosion of the nutritional foundation that the eye's protective system depends on, happening quietly in the background of a life where eye health was addressed once a year at an optometrist's appointment where the conversation was about prescription lenses and intraocular pressure, not about macular pigment density or dietary carotenoid status. I want to tell you about Eli now. Eli came to see me at 68 years old. He had been wearing glasses since his mid-40s and considered himself relatively well-informed about his eye health. He saw his optometrist every year without fail. He had good quality glasses, and he had been told 2 years earlier that he had early-stage changes in the macula of his right eye consistent with the beginning of dry age-related macular degeneration. His optometrist had mentioned that he should consider an AREDS supplement, the specific formulation tested in the landmark AMD clinical trial, and Eli had dutifully purchased a bottle, taken it for about 3 months, then quietly stopped when he noticed no obvious change and began to doubt whether it was doing anything. What brought Eli to me was not his eye appointment, it was fatigue and a general sense that he was not feeling as sharp as he used to. During our initial consultation, I asked about his diet in detail. Eli was a man who had lived alone for several years since his wife passed, and his cooking had simplified considerably. Breakfast was toast with butter and coffee, lunch was usually a sandwich or something from a can, dinner was often a ready meal or takeaway several nights a week. Vegetables appeared occasionally, some peas with dinner, a tomato and a sandwich, but dark leafy greens were essentially absent from his diet. He could not remember the last time he had eaten cooked spinach or kale. He ate eggs perhaps once a week. When I ran a full nutritional panel alongside his standard bloods, his serum lutein and zeaxanthin levels came back in the lowest quartile for his age group. Not completely absent, the body maintains some circulating levels even with poor intake, but meaningfully low, certainly not at the levels associated with adequate macular pigment support. When I asked him whether anyone had ever discussed his dietary lutein intake in the context of his macular degeneration diagnosis, he looked at me with genuine surprise. His optometrist had recommended the supplement. His GP had noted the eye findings on his record. Nobody had sat down with him and explained that the single most modifiable dietary factor in age-related macular degeneration progression was the presence of these specific carotenoids in his daily food, and that his current diet was providing almost none of them. We made a plan together. We reintroduced the AREDS-based supplement that he had stopped, now with a clear understanding of why it contained what it contained and what it was doing biologically. We worked on 2 or 3 simple dietary changes, adding 2 eggs to his breakfast most mornings, incorporating a portion of cooked spinach or kale into his dinner several times a week, and adding an avocado to his weekly shop because the healthy fat in avocado significantly enhances lutein absorption from other foods consumed in the same meal. These were not dramatic changes. Eli was not going to become a plant-based health enthusiast overnight, but they were achievable, sustainable, and meaningful. At his follow-up 4 months later, Eli told me his energy was better, which was partly related to other nutritional work we had done simultaneously. But more significantly, his next ophthalmology review had noted that the early macular changes in his right eye appeared stable, with no measurable progression from the previous year's findings. His ophthalmologist had commented positively on his supplement adherence. Eli told me, and this is the part that stayed with me, that knowing there was something specific he could do, something with a real biological rationale that he understood, made him feel less passive about his diagnosis, less like he was just waiting for his vision to deteriorate and hoping it happened slowly, more like he was an active participant in protecting something he valued enormously. That shift, from passive patient to informed participant, is what I'm trying to create with every video I make. Let me give you the practical steps to bring to your next appointment. The first is to ask your eye care provider specifically about macular pigment optical density. MPOD can be measured non-invasively in some optometry and ophthalmology settings using a device called a heterochromatic flicker photometry instrument. Not every practice has this equipment, but it is worth asking about, particularly if you have any family history of macular degeneration or have been told you have early macular changes yourself. This measurement gives a direct picture of your macular lutein and zeaxanthin status in a way that a blood test alone cannot. The second is to ask your GP about serum lutein and zeaxanthin testing as part of your nutritional review. This is not a standard panel item in most general practices, and you may need to specifically request it or be referred to a nutritional medicine practitioner. But having a baseline measurement gives you and your care team a concrete starting point. The third is to evaluate your dietary sources honestly. Cooked kale and cooked spinach are the richest sources of lutein available. Cooking breaks down the plant cell walls and significantly increases lutein bioavailability compared to raw consumption. 2 eggs per day provides a smaller but highly bioavailable lutein contribution. Consuming lutein-containing foods alongside healthy fats, olive oil on your greens, avocado at the same meal, eggs cooked in a small amount of butter or olive oil, meaningfully increases absorption. If your current diet is consistently low in these foods, a targeted supplement conversation with your physician is warranted. The fourth is to discuss the AREDS2 formulation specifically if you have been told you have any stage of age-related macular degeneration. The AREDS2 formulation, which includes lutein and zeaxanthin as the carotenoid components, replacing the beta-carotene used in the original AREDS formula, is the version with the most current evidence supporting its use in AMD management. If you are currently taking an older AREDS supplement containing beta-carotene, ask your eye care provider whether switching to the AREDS 2 formulation is appropriate for you. The fifth is to consider the full antioxidant picture of your diet alongside lutein specifically. Vitamins C and E, zinc, and the omega-3 fatty acids DHA and EPA are all components of the AREDS 2 formulation and all have their own evidence base in retinal health. A diet rich in colorful vegetables and fruits, fatty fish, nuts and seeds, and healthy oils is not just generally good dietary advice. It is specific support for the biological systems that protect your vision at the cellular level every single day. Your vision is not something to be passive about after 60. The changes that happen in the aging eye are real, and some of them are irreversible once they reach an advanced stage. But the window between early change and significant loss is often measured in years. And what happens in that window, the dietary choices made, the nutritional gaps identified and addressed, the supplements taken consistently and for the right reasons, genuinely matters to the trajectory of what comes next. I have watched patients make meaningful differences to their eye health trajectory through nutritional interventions that took nothing more than consistency and the right information. Eli is one of them. I am Dr. Michael Kent, and I make these videos because I believe that the adults who are most at risk of preventable health decline are often the ones who are never given the specific, evidence-based, actionable information they need to do something about it. That gap is not acceptable to me, and closing it, one video at a time, one conversation at a time, is what this channel is for. Right now, before you do anything else, scroll down and leave your age and your city in the comments below. Just those two things. I read every single one. I want to know who is watching, where in the world people are sitting with vision concerns that have never been fully addressed, and what topics matter most to the people who need this channel most. And if you are not already subscribed, please subscribe right now. Every week I am putting out content built specifically for adults over 50 who are serious about their health and want something real, something grounded in evidence, something they can actually use. Subscribe so you do not miss what is coming next. I will see you in the next video. This video is produced by Dr. Michael Kent for general educational and informational purposes only. Nothing presented in this video constitutes medical advice, clinical diagnosis, or a recommendation to start, stop, or modify any medication, supplement, dietary regimen, or treatment plan. All content is intended solely to support informed conversations between viewers and their qualified, licensed healthcare providers. Vision conditions including age-related macular degeneration, cataracts, and diabetic retinopathy have multiple potential causes and vary significantly between individuals. Nutritional and dietary information discussed in this video represents general health education and does not account for individual medical histories, allergies, contraindications, or clinical circumstances. Always consult your ophthalmologist, optometrist, physician, or licensed healthcare professional before making changes to your supplement regimen or diet in relation to any eye condition. The patient experience referenced in this video is presented in a generalized, non-identifying, illustrative format for educational purposes only. It does not represent a guaranteed outcome, a typical clinical result, or an endorsement of any specific supplement brand or dietary product. Dr. Michael Kent does not endorse any specific supplement brand, pharmaceutical product, or commercial health service. References to clinical studies in this video are presented for general educational context and are not a substitute for individualized professional medical guidance. If you are experiencing sudden changes in vision, new floaters, flashes of light, significant visual disturbance, or any other acute eye symptoms, seek medical attention promptly. If you are experiencing a medical emergency, contact your local emergency services immediately. This content is not intended to diagnose, treat, cure, or prevent any disease or medical condition. Dr. Michael Kent, Senior Health Education, for educational purposes only.